On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Suicide Prevention. My name is Rick Condravy, and I'll be your moderator for this program. Now I'd like to introduce our speaker for the webinar, Christopher Mamrol. Chris is a Patient Safety Liaison with the Pennsylvania Patient Safety Authority for the Southwest region of Pennsylvania and offers an extensive and well-rounded patient safety background to his assigned healthcare facilities. Before joining the authority, Chris worked at Montgomery County Emergency Services, Inc., serving in multiple roles from psychiatric technician to Director of Safety and Quality Systems, Risk Manager, Patient Safety Officer, and Director of Performance Improvement. Chris is a member of the American Psychiatric Nurses Association, the National Patient Safety Foundation, and is a Lean Six Sigma Black Belt. Chris, now I'll turn the program over to you.
Thank you, Rick. We'll start off on our screen. You can see our objectives for today. We'll be talking about some of the environmental and behavioral risk factors that contribute to risk for suicide. We'll also discuss protective factors and warning signs. We're going to take a look at a couple different tools for assessing risk of suicide behaviors, comparing and contrasting those. And finally, we'll discuss some strategies to improve suicide prevention practices within your own facilities and organizations. Start off by discussing the scope of the problem we're discussing today. The prevalence of suicide currently in 2016, it's the 11th leading cause of death. It was number 10 via the CDC data in 2015. That may be adjusted over the past decade. It's hovered right around the 10 to 15th rank. Cause for concern now, and you can see up on the screen, is there's those three age ranges where it's the second leading cause of death. So you can see it's a major problem for young adults and middle-aged adults. We also see a very high rate in the elderly, though it is not one of the leading causes of death. It's right around the high teens. We also see an increase in rates among military personnel and within the LBGT community. Nationally, there's almost 13 deaths per 100,000 people per year. The rate is a lot higher for males as far as completion of suicide. Males, it's ranked 7th, whereas for females, it's 25th. Give you a little bit more specific data on Pennsylvania itself. I'll show this slide. I won't read through it all, but you can see the cost of suicide in Pennsylvania. The real telling thing here to me is that one person dies by suicide within the state every 5 hours. So we're losing 4 to 5 people a day to this problem. So it's definitely worthy of our attention. Again, in Pennsylvania, there's a similar discrepancy between males and females, and the rate is slightly higher within Pennsylvania compared to the national average. We kind of scheduled this webinar after the holidays. I know a lot of people come out of the holidays feeling a little depressed, so we wanted to have a nice, lighthearted presentation for you guys today to hopefully kind of combat some of that. But I also wanted to discuss the common myth that suicide is more frequent around the holidays. I've heard that a lot, and I think it's kind of dying out, and more people are aware that that's not actually the case. We actually see a spike in suicide rates in the late spring, early summer. There's a couple different theories for why this might be. It may be that the presence of family and friends around the holidays, while maybe not the best thing for all of us, is comforting and a support system that's there. And once that's gone, it may lead to more completed suicides. It could be the change in weather, the emphasis on new life and rebirth creates a contrast to some of the dark thoughts and feelings people have. Now that we've kind of discussed the scope of the problem, I want to get into some of the warning signs and risk factors. I've divided it into 3 different categories for the warning signs, and I believe 4 categories for risk factors. But I wanted to discuss a little bit about the difference between the two. When we discuss warning signs, we're talking about immediate risk, whereas when we discuss risk factors, we're discussing those things that are present in people who more commonly present in people who attempt or complete suicide. So risk factors show an increased risk for suicide attempts behaviors, but there's no to little indication about immediate risk. I'll draw a comparison to an acute care setting, heart attack, heart disease. Talking about risk factors for a heart attack, you would think of things like smoking, obesity, high cholesterol. Those would be your risk factors, whereas your warning signs would be your immediate risk signs, your chest pain, your shortness of breath. So we'll talk about really the immediate warning signs first and then move on towards risk factors. First group I want to talk about is speech, what people say. Another one of the myths that I've heard quite frequently is that people that plan to kill themselves don't talk about it. I've even heard that you can plant the idea of suicide in somebody's head by asking them about it. These are both big myths. And frankly, about 2/3 of people who commit suicide do signal their intention verbally shortly before they act. Things like saying they're feeling a burden, they feel pain, they don't see a reason to live, expressing thoughts about killing themselves, obviously, thoughts about wondering what it might be like if they were dead. Those kind of things are very important to watch out for and need for immediate intervention. Next group is behaviors you may see for somebody that's thinking about imminent suicide. Increased substance use, alcohol, drugs, those kinds of things, other reckless behaviors, withdrawing and isolating, not attending social gatherings they would before, withdrawing from peers, family members, those kinds of things. Sleeping a lot more, sleeping less. Giving away possessions is a big one. This might be coupled with visiting and calling friends and family to say goodbye. Signs of aggression, it can manifest as irritable mood, and we'll get into that. Also, searching for lethal means. This can be pretty direct as far as going out, buying a gun, things like that, scoping out a bridge, or online searches of ways to kill yourself and ways to get guns, to get pills, to get different lethal means. The last group of warning signs we'll talk about is mood. These, and I won't go through them, but on the screen you can see a lot of the moods that are frequently exhibited by individuals in the context before they attempt or commit suicide. Depression being very common, and of course anxiety, and then that irritability, rage that we kind of discussed among the behaviors. Now that we covered the warning signs, I want to touch on some of the risk factors. As I discussed risk factors, I'm also going to mention protective factors, very converse. Obviously, so where there is a risk factor, we'll take the first one. If a person has a mental health disorder, there is protective factors such as getting satisfactory mental health care. There's also the inverse of that. If the person's dissatisfied with their mental health care, that can be an additional risk factor. Now, the weight of these risk factors varies. So each one doesn't have the same impact as the next. And then even among individuals, these risk factors have different weights. So one factor that might impact one person greatly might not have as large of an impact on another individual. So it's really important to take it on an individual level and look at it that way. And when we talk about high-risk individuals, we're typically looking at a combination of a lot of risk factors. There's kind of a constellation of multiple risk factors from different categories that kind of factor in. And it's important that we identify these risk factors, we talk about these risk factors, because that's what can be used to find the emphasis for interventions and prevention of suicidal acts, both on an individual and a community level. So we take this information about risk factors, see what's present, and then that helps contribute to going about creating a strategic plan for how to address that issue. So you see the ones related to health here. I mentioned mental health disorders, depression, bipolar, other mental health disorders, schizophrenia, substance abuse, very closely tied to that, serious or chronic health conditions, terminal illnesses, cancer, things like that, chronic pain, also a risk factor. Next, I'll discuss stress. I'd like to just divide stress into acute or chronic. When we talk about acute stress as a suicide risk factor, it's typically a loss. Most commonly, people think of a death, whether it's the death of a loved one, a family member, or a close friend. It could be a death of a pet. Divorce is also another loss of a relationship or breakup with a boyfriend, girlfriend. sometimes this can be a good thing, but a lot of times it is a contributing. It leaves a person feeling lonely, maybe without a support. Loss of a job, which can lead to financial hardships, things like that. Some other losses, we could talk about loss of freedom. If there's a pending incarceration, that's one that I believe is frequently overlooked when we talk about recent losses. And then loss of housing, which could be coupled with a loss of job, coming with financial difficulties. Pending homelessness is definitely an acute stressor. When we talk about chronic or prolonged stress, we talk about harassment and bullying. Those are things that we would see very frequently in the LBGT community, very closely tied with relationships problems, whether an abusive relationship or whether a cycle of breakups and getting back together, those kind of things. And then related to the loss of a job, if that is prolonged, the prolonged financial hardships, the prolonged kind of feeling of not having a purpose, those kind of things can contribute to a chronic stress and increase the risk for suicidal behaviors. Next topic we'll touch on is access to lethal means. Now, I have in parentheses there, I want to specify just having access to lethal means isn't really a risk factor in itself. It has to be coupled with suicidal thoughts. There's tons of people that have access to firearms and prescription pills, and we don't really consider it a risk factor because they might not be having these thoughts or other risk factors with it. So in a vacuum, this isn't as big a factor, but when you couple it with suicidal thoughts, it is a major one. Firearms being the big one. We talk about drugs. I know a lot of times people come to mind street drugs. This also includes prescription drugs, painkillers, things like Tylenol, Benadryl, and then I have on there chemicals. Chemicals, when you think of things like bleach, Drano, we've seen these things ingested as part of a suicidal action. Other lethal means would be bridges. The big one everyone I think thinks of is the Golden Gate Bridge. And I don't know if you know that there's patrols along the Golden Gate Bridge. There's signs, things like that. They're actually in the process now of building a net beneath the bridge to try and catch people that may jump. And I'd like to give a shout out to the staff of Montgomery County Emergency Service that worked very hard having signs placed at the area bridges around that facility, and also working closely with SEPTA to place suicide awareness signs with a hotline number on train tracks and train stations, which I think is a very important setting that a lot of people overlook. So I just want to give them a little bit of credit there. The last risk factor we'll talk about is suicide attempts. The big one, of course, the person actually committing suicide or committing a suicide attempt themselves. That's a bad choice of words. And we see actually an increase in the risk for completed suicide with every attempt. And this is actually very largely spiked in the first few weeks after an attempt. Now, a lot of times that situation does result in hospitalization. So there is a level of protection there, but it's something to be aware of, that if somebody does have a past suicide attempt, that it is important to consider, no matter how long ago. Family history also plays a role. Now, this could be a completed suicide or any suicide attempts by a family member. We'll count close friends, things like that among that as well. Some other ways that suicide attempts, if a person witnesses a suicide attempt by either a family or friend, acquaintance, that can be a very traumatic experience and has been shown to be a risk factor. And then the telling of suicide. It might be a glory or a sensationalized account of suicide for greater benefit or valiant reasons, those kinds of things. Important to keep an eye out for and pay attention to. Now that we've identified some of these risk factors, how do we see if they're present? Identifying these risk factors, we're looking for a risk level of the person that we're not trying to predict suicide. There's no real way to do that. We're just trying to determine how much of a risk this person has of going through with some suicidal actions. People should be universally screened. About 70% of people that complete suicide have contact with a healthcare professional within the 6 months to a year before they commit the act. This is not necessarily a behavioral health professional. It may be a primary care physician. It might be an emergency department. It could be an EMT. So there's a lot of different healthcare professionals that I think need to be aware of the risk and know what to look out for. Once we identify the risk, as I mentioned before, that can really be used to identify the appropriate interventions that can come from. Using an evidence-based screening tool, when you have somebody that screens positive for suicide risk of any level, the next step is really to get them assessed by a competent healthcare professional, so a behavioral health or a mental health professional. And really, this referral to therapy is an okay action. I know it may seem like kind of passing the buck. We don't know how to handle this. We're passing it to the next person. But that referral to therapy is an evidence-based practice, and it's a good way to support those who might be at risk for suicide. Ideally, that referral is made within a 7-day time period, but if not, any referral is helpful. So now we talked about who should be screened, why we want to screen them. Let's talk about some of the tools we have, and I've listed them here. These are varying different lengths. I'll touch base on all of them briefly in the following slides, but research has shown that even these brief screening tools can really identify individuals at risk and overall decrease the prevalence of the problem in the community. An important aspect is if somebody does screen positive, they need to be reassessed. You want to look for changes in any of those risk factors that are modifiable. If the person's inpatient, you also want to be doing a reassessment on a regular basis, ideally every shift, if not at least daily, depending on the setting and the level of risk. First tools I'll assess on is I'll touch on is the patient health questionnaire. This has two forms, the PHQ-9, which is 9 items, and the PHQ-2, which is, wait for it, 2 items. It's actually the first 2 items from the PHQ-9. This was a tool that was developed through a grant from Pfizer. Its purpose is really not to specifically identify risk for suicide, but as a screening for depression. So the questions focus on if the person has little interest and pleasure in doing things, or if they're feeling down, depressed, hopeless. Now, if somebody tests positive for either of these questions, you really should further evaluate with the PHQ-9. PHQ-9, very similar. Again, the questions are scored 0 to 3. It's, again, not for suicide risk, more for determining level of depression. We talk about the scores. A score of 5 is mild depression, 10 is moderate. Once we get above 10, you have a sensitivity of almost 90% for this tool and a specificity of almost 90%. That is the true positive and the true negative. So decent scientific backing there. When you get to a score of 15, we're talking about moderately severe depression, and 20 is a score of severe depression. The last question, I don't know if you guys can see it on your screens on the bottom there, is unscored, and it's really to gather more information about where the person might be currently with suicidal issues. In order to refer somebody to treatment, you're looking for a positive on one of the first 2 items, and then a score on that last unscored item is either somewhat difficult or above. And I believe I had the link on the previous slide of where those tools are available, those 2 screening tools. The next tool I'm going to discuss is the Columbia Suicide Severity Rating Scale. This has a lot of evidence base behind it. Less false positives than the PHQ. Its sensitivity is approaching the high 90s, depending on what study you read. The nice thing about the Columbia Suicide Severity Rating Scale, one of the nice things, it's available in, I believe, over 100 languages, country-specific languages at this point, and multiple versions for different care settings, different populations, whether it be youth, young adults, older adults, as well as assessing for when suicidal ideation may be present, whether it's recent, whether it's since the last contact, whether it's lifetime. For an inpatient setting, there's also a version that's designed for frequent assessment that can be used every shift, every day. Now, I'll mention I have on here that it can be given university and no mental health training is required to administer. So it's not necessarily just a behavioral health tool. I would caution that that doesn't mean that it can be given without any training whatsoever, however. It does require training on how to administer, how to score, how to interpret the tool. That is available for free along with all the screening tools themselves on the Columbia website. They also have a guide for triage, which in a lot of settings I believe is very helpful to really look at what your score is and what the suggested interventions could be following that score. The next tool I'll touch on is the Suicide Behaviors Questionnaire, the revised version. This divides the question into 4 different domains: lifetime ideation and suicide attempts, any thoughts of suicidal ideation over the last 12 months, if they've ever threatened or told somebody that they might commit suicide, and then how a self-report of how likely it is they think that they would attempt suicide in the future. The scoring on this ranges from 3 to 18. It's designed for adults. I'll specify that. It can be scored differently based on whether it's a general population or on a psych inpatient basis. For the general population, you're looking at a score of 7 or above. And again, your true positive, true false are in the mid 90% tile range there. When looking at psych inpatients, the threshold's a little bit higher. They're looking for a score of 8 or above. Your sensitivity is about 80%, where your specificity is up at around 91%. So a little bit better rating as far as use in the general population than on an inpatient unit. The next tool I'm going to touch on isn't really a tool per se. It's more of and I'll call it a flexible therapeutic framework. It does use a form, their suicide status form, that's divided into 4 parts. And really the focus of this framework is the patient-therapist collaboration and really building up that relationship between the therapist and patient with empathy and a non-judgmental attitude. So it's very important to have the patient's input when using this framework. It's interesting that the initial assessment, the initial screening is actually completed by the patient and the clinician, different parts, and then kind of compared and built from there. Then from that, there's forms kind of guiding the creation of a treatment plan, where to go from there. And it's very important that the patient have input into that process at this point. You want to, as you're tracking the progress and the changes in risk factors, things like that, it's important that the patient really verbalize and be willing to give input on what is and what isn't working of the treatment plan, and it can be modified and revised to kind of fit what the evolving needs are. And lastly, the last step is determining outcomes, which is pretty much just a reassessment of that initial screening and seeing what support is there moving forward. This would be kind of around your time of discharge, and really kind of an end to that therapeutic relationship or changing of that therapeutic relationship as far as what the disposition is going to be. The next, again, there's a specific tool, but I'll define this more as a suite of tools, is the Beck Scale for Suicide Ideation. I don't know how many of you are familiar with Beck Institute, but located in the wonderful Commonwealth of Pennsylvania, right in Ballackinwood. It was founded by Dr. Aaron Beck, who did a lot of work on cognitive behavioral therapy at Penn. He and his daughter, Dr. Judith Beck, founded the Institute to kind of provide CBT resources as well as tools for assessing not just suicide, but anxiety, depression, hopelessness, those kind of things. These suite of tools are a little different from most of the others I've shared today in that they're only available through purchase. I believe it's the Pearson Assessment site where you have to go through to get these materials. And, of course, the Beck Institute staff are more than willing and really great at what they do, at coming out and consulting and helping train staff. This is a more intensive approach, I'll say, to addressing the issue, and probably more designed for the behavioral health setting rather than some of the acute care setting or ambulatory settings that many of you may be from. Speaking of the acute care settings, I wanted to touch base on something designed specifically for you. The Emergency Department Safety Assessment and Follow-Up Evaluation, the ED Safe suite of tools. This, again, is a source of materials available through the Suicide Prevention Resource Center. So not just one screening tool or things like that. And specifically designed for emergency department staff. The provider tools include a patient safety screener. This is an initial screen, and it actually includes, don't quote me on this, but I'm sure it includes the 2 questions from the PHQ-2, as well as, I believe, 4 questions from various Columbia suicide scales. If there's positive screen on that patient safety screener with those questions, there is a secondary screener available, and the purpose of that is really to assess if a referral to a mental health treatment is necessary at that time. If referral to mental health treatment isn't necessary, there's also within this suite of materials patient handouts available. I believe they have a wallet card for how to stay safe. That includes links to the suicide prevention hotline, as well as a template for a personal safety plan. I'll get into personal safety plans a little bit in a little bit more detail later on, but it's one of the best tools, one of the best interventions for addressing somebody with a high risk for suicide. This template is pretty basic. It's pretty easy. There's checkboxes, things like that, suggestions of what might be added, and it can be completed by the patient independently without the help of a healthcare professional. Now, a lot of facilities that choose to use the ED Safe suite of materials opt to follow that up with the safety card, which is the suicide assessment 5-step evaluation and triage. This is a pocket card for providers that kind of gives a little bit more in depth once somebody may screen positive for suicide risk of various levels, to kind of break that down. It helps with documenting that out, figuring out what the best intervention can be. So it guides you through the identifying risk factors, protective factors, conducting an inquiry, basically questioning about what kind of suicidal thoughts or plans the person may have. Then taking the information from those first 3 items and really coming up with a risk level, whether that be high, moderate, low, and then looking at that risk level, there's suggestions of interventions. And then, of course, the 5th step in that, always important, because if you didn't document it didn't happen, is a reminder to document that risk, the rationale, how you determine that level of risk, and basically what was done about it and what follow-up will be done. That's pretty much the end of specific tools or suites of tools. I did want to touch on 2 training programs that are out there for your staff, for the population in general, actually, as well. The first one I'll touch on is the ASSIST model. It's Applied Suicide Intervention Skills Training. This has scientific backing. It's an intervention model. They liken it to kind of a suicide first aid. It's not really designed for healthcare specifically, but it is designed to match up with the National Action Alliance for Suicide Prevention's clinical workforce training guidelines. So even though it may not be designed for just healthcare workers, it does have healthcare workers in mind and does provide the information that the National Action Alliance is looking for in healthcare training. They offer several ASSIST workshops, most in person. I believe they do some online-based training, and typically those are 2-day programs. They do have train the trainer options and things like that that are a little bit longer than maybe to kind of train your staff in a little bit more reasonable amount of time. The second training program that I'm going to touch on is QPR. QPR stands for Question, Persuade, Refer. It was actually started out on the western part of the country, I believe in Washington State, in the late 90s. And I know a lot of people hear the QPR, you think of CPR, and that's kind of the idea that they had in mind. They want to kind of have this be an emergency intervention similar to CPR or the Heimlich maneuver. And ideally, I think they would like that everyone in the country is aware of what these are and knows how to implement it to some degree. Really, the focus is on how to interview a potentially suicidal person, determining their immediate level of risk from that interview, and then finding ways to reduce that level of risk through, again, safety planning and referral to treatment if necessary. There is a very strong evidence base behind this program, and they offer several different levels, screening either for non-healthcare professionals or healthcare professionals. When we talk about their trainings and for healthcare professionals, it is further divided by disciplines, whether it's medical staff, nursing, techs, things like that. There's a specific training on triage, how to ask these questions and then determine what should be done with the person. So very good for the ED settings, primary care settings, things like that. And then for a little bit more in depth, potentially with the behavioral health setting, they have a risk assessment and management and have really to mitigate that risk to the next level, I'll say. So definitely a program worth looking into if you're looking for a more comprehensive training program for your staff. And again, train the trainers available. And the nice thing is, I believe the vast majority, if not all, of the QPR trainings are available online. The only ones that might need to be in person are the train-the-trainer programs, just because they're a little bit more in depth and require a little bit more practice and hands-on time. We talked about interpersonal factors up until this point, interviewing and things like that. I also wanted to touch on environmental hazards. Important to look at the way that your facility is designed, to kind of look at it with a critical eye, but it's not a be-all, end-all. I kind of liken it to child-proofing your home. You know, you can go around, and those of you with children, you know, you can go around, you can put all the drawer locks and cabinet locks and those little bubbles on the doorknobs that you want, and it's, at least in my daughter's case, it takes about 30 seconds for them to figure it out and get by them. You know, then you try putting things on a higher shelf, but then they get taller, they figure out to pull a chair. So, you know, it's an important step. You want to try and reduce the risk as much as possible as you can in an environment, but you're never going to be able to eliminate it entirely. And when we talk about individuals attempting self-harm, never underestimate the level of creativity. You know, we've heard a lot of people saying that, oh, no one would ever hurt themselves that way. And every time I hear that, I think back to a story that was relayed to me. There was a patient, and I can't speak to the level of observation, anything like that, but this patient was on a mental health care unit that was very good at mitigating their environmental risks. You know, no ligature points. This patient went into the restroom. There was breakaway shower curtain rods. You know, the paper towel dispensers were slanted so they couldn't be used as a ligature point. The pipes were enclosed, things like that. In this patient, there was a dirty linen bin in the restroom, and this patient pulled out a sheet that another patient had discarded in that linen bin, tied the sheet around the neck, and put the other end into the toilet and flushed the toilet. And the sheet was sucked down into the toilet plumbing around that U-bend in the toilet and caught and pulled tight around the patient's neck. Thankfully, a good outcome. The patient was discovered rather quickly and liberated from that contraption. But it just always reminds me every time I hear that, you know, no patient's going to harm themselves that way. It's amazing how creative people can be when they really feel that urge to harm themselves. That being said, I did mention ligature points and like the breakaway shower curtain rods. Hanging, you see in pretty much 3/4 of the suicide attempts on an inpatient unit or in an office setting. So it is important to kind of look for those things. This next slide is actually pulled from a Pennsylvania Patient Safety Authority tool. It's broken down specifically focusing on a behavioral health room, but I think it is applicable to acute care as well. I'm not going to take you through all the things. If you actually click on the picture, and it was available on the previous slide as well, but if you click on the picture, it'll take you to the link that breaks down each numbered item there. But it's important to think of, you know, non-safety mirrors, windows can be broken, and shards can be used for cutting. Glass frames of pictures, shoelaces, clothing, belts, those kinds of things it's important to be aware of. Plastic bags and trash cans, something not everyone thinks of. But when we talked, you know, I mentioned that hanging is the most common. Within that, sheets are the most common material used, and the data kind of supports that. That's what we see most frequently used as a anchor to a ligature point. Now, looking at this beyond, if this wasn't a behavioral health room, acute care rooms, it's important to consider some of the other things. You may have drawers with bandages in them that can be used, call belt cords, different types of elastic tubing, whether it's IV tubing, oxygen tubing. Those could be strong enough to support somebody's weight if they chose to try and hang themselves. Now, assessing this risk, you want to do on a regular basis. There's really two major resources out there. The first one being the VA. The VA does provide a environment of care checklist. I'll use the word extensive. I believe it's available as an Excel spreadsheet, kind of divided into different areas, rooms. So there's a sheet for the bedroom with a checklist. There's a sheet for the bathroom with a checklist, for a kitchen area, for hallways, those kind of things, kind of broken down a little bit more specifically. Still very extensive, but I would caution it doesn't always include everything. So it's generally a good idea to have more than one person doing your environmental rounds, looking for these hazards, these risk areas. It might be a good idea to have one person manning the checklist and another kind of looking around. And I would also say that it might be a good idea to have those people rotated, because you never know what new eyes are going to see. My wife and I just recently, about a year ago, moved into a new construction home. I don't know how many of you have gone through that process, but there's several steps of inspection where you can kind of walk around and you're looking for, little bubbles in the drywall, gaps between your baseboards, things like that. The builder's very willing to fix all those little, I'll call them nitpicky things as you're going through the process. So there's probably half a dozen opportunities to walk through before settlement. And then because of settling with different weather and foundation issues and things like that, there's typically an opportunity about 10 months to a year afterwards to correct other issues that may pop up. So we moved in about a year ago, and I'd say over the first 8 months we had, 2-3 dozen people coming through our house, a lot of them with a critical eye, kind of looking through, focusing on those things. And they pointed out many things we had noticed, many things we didn't. And about 8 months after we moved in, I had a friend of mine. I was talking to him in the kitchen, explaining the process because he had been asking, and saying, hey, they're gonna fix these things after a year. And he's like, oh, like your kitchen island being crooked. And I looked at my kitchen island, and the countertop is probably a quarter of an inch off from one end to the other, which, like I said, 3 dozen people with a critical eye going through this house had not noticed that. So it really goes to show new eyes will spot new problems. And now really the only problem is once you see something like that, you can't unsee it. But in the case of looking for safety risks, that's a very good thing. Now, once you've identified those risks, the VA does also offer a environmental program service guide to kind of pick tools. Now, this isn't something, they're not making specific recommendations for materials, things like that, but if you follow that link, it's something that really is showing what's out there as far as materials are that might have, like ligature-proof door handles, specially designed behavioral health, paper towel dispensers or soap dispensers, things like that. So that's really, the second part is really what you can do about it after you have identified a potential risk. The other resource I mentioned two, the other common one that's recommended is the New York State Office of Mental Health, and they have a systems guideline. Again, this webinar doesn't recommend any one tool or guide over another, just kind of trying to provide you with information of what's out there. This one, again, like the VA tool, very extensive, focusing on what materials are out there. They, again, do not recommend particular products or materials, but just kind of showing you one-stop shop for risk mitigation materials. And like I said, it's sorted by openings and closures, toileting accessories, light fixtures, pretty much anything you can imagine. So that covers what is in the environment that you provide. I want to touch briefly on what your patients bring into that environment. And I know patient searches can be a tricky topic, and it's always a balancing act between balancing dignity versus safety. but really safety should always be the priority. It's up to your facility specifically to kind of decide where you want to draw that line, but safety really should be the top priority in that debate. And when you prioritize safety, you also see other benefits like things that might be brought in and used for harm against another or violence directed at others. You'll also see a reduction there. So we've reduced the risk of the environment. We've brought the person in, limited what they can bring in that may be able to help themselves, but we need to keep an eye on them. So we have some form of rounding or safety checks, whether this is every hour, every 15 minutes, things like that. I'm sure most of you have something in place to monitor your patients and document that. I would say that it's important to evaluate your current documentation. Is it really clinically useful? We see a lot of checklists that have behavior on them, but it's superficial things like sitting watching TV, talking with peers. Really, you're looking for something a little bit more involved. So you educate your staff, so instead of having watching TV, you could have a column that says, watching TV, shifting in chair, wringing their hands. And that would indicate some anxiety and agitation. So that gives you more information. And really, once you're getting that assessment of behavior and mood, you're looking for that development over time. I'll liken it to like a telemetry strip. You want to see trends and patterns. Is somebody getting agitated or more withdrawn around meal times or right before bedtime? Is there some history of trauma that might be playing a role that could be further explored? Those kinds of things. And looking at those and looking at them with a critical eye can allow for an earlier intervention, an opportunity to kind of step in and take action before it gets to a critical level, I'll say. The other thing is watch predictability. If you're coming around every 15 minutes and your patients know you're coming around every 15 minutes, they know they have 15 minutes to do things that they might not want witnessed. So stagger it up. Kind of, you don't want to follow the same pattern. You don't want to go the same order of rooms. I would caution not to, instead of keeping your rounds 15 minutes apart for every patient, be careful not to do, one patient 2 minutes apart, and then you have another 20, 25 minutes in between the next set of rounds. That could be dangerous as well. So you want them predictable, but you still want to be checking up on everybody on a frequent basis. And really the important part of that is you're checking up on them, but you also want to engage with your patients. You just don't want to monitor them, feel like they're being watched or observed. It's important to really get in there and engage. And this is probably one of the most important aspects of improving safety on an inpatient unit, building that therapeutic relationship, empathy, respect. You never want your staff to shame an individual for having suicidal ideations or making them feel less about it. And it's really important to build that trust. When I think about engaging with somebody that might be having suicidal thoughts or feeling hopeless, there's an anonymous quote that always comes to mind that I really like that I'll share with you guys, and suicide doesn't end the chances of life getting worse. It eliminates the possibility of it ever getting better. And to me, that's a good framework to approach the problem. Is, if you don't commit suicide, there is always a chance that life will get better. And I think that message of hope is very important and a very important part of engagement. So we'll do a quick review and then move to some new stuff here. Really, the first step is managing your environment. We talked about access to lethal means, whether that be contraband snuck in, whether it's ligature points around your unit, those kind of things. You want to prevent elopement because if somebody's feeling suicidal, they can't see an opportunity in an inpatient setting. Elopement is an option. Observation, your rounding, your safety checks, those kinds of things, very important. With it comes the engagement piece. It's when we're talking about somebody with a high risk of suicide, I liken it to the kind of the ICU of acute care. You really want to keep an eye on what's going on and make sure you're aware of changes in that person's mood, behaviors, those kinds of things. We talked about the risk and some of the protective factors as well as warning signs. And the last thing on here is safety plan, which we have touched on briefly, but I wanted to go into a little bit more in depth. Now, developing a safety plan can involve some other things working on that problem solving, CBT, DBT can be used to help teach coping skills. It doesn't need to get that in depth. It's wonderful if it does, but it's not necessary. So when we talk about a safety plan, I hope no one out there is going, safety plan, like a no harm contract, a no harm plan, a contract for safety. Not the same thing. Really, I know the contract for safety has been around for a while. I know it's dropping out of use, thankfully, because there's really no research behind it, and it's not really expert recommended at this point. Whereas your safety planning is more evidence-based. I will say that if a strong therapeutic relationship is present, that a contract for safety can be replaced with, we'll call it an alliance for safety, which is really emphasizing partnership between the patient and the clinician to really avoid acts of self-harm. So safety plan itself, like I said, not a contract for safety, evidence-based, ideally developed while the person is inpatient. There are models used for that the patient can develop on their own, but really if you develop an inpatient, you can give the patient an opportunity to demonstrate that plan, to kind of look at that plan with each contact, kind of assess it, modify it until it's really ideal for them. There should be a level of ownership that they have over that plan. You want it to be patient-centered. You don't want something that's kind of just a canned intervention that you're handing out. You really want it individualized within all the components of your plan. And really, the focus of the plan, the purpose of the plan is to help the person get help prior to acting on any suicidal thoughts they may have. Now, what that process looks like, how they go about help, what kind of help they seek out can be different, but that's really the overarching theme of the safety plan. So, like I said, there's many different forms of safety plans, but they all have generally the same components. The first step is recognition of warning signs. So the early indicators of stress, acute stress, you're going to want the person to kind of identify what it is specifically in them that presents. It's very helpful if that person can identify their triggers, either internal, their own thoughts, their own feelings that they may be having, or external. If there's things that they witness, or, if the violence could be a trigger, witnessing violence, things like that. Going from there, you want to discuss and identify how the person can keep themselves safe. You want to discuss what kind of coping strategies, what kind of actions. It's also helpful to have some affirmations or thoughts. When we talk about building up hope, these affirmations can help keep themselves positive, motivated, hopeful. A lot of times it's a reminder that, hey, you have children that are counting on you. Those without children and pets, you might be a cat or a dog parent, and that's an important thing to keep in mind and remember. In addition to that, you're going to want to recognize and list the support system that the person has, social contacts they can reach out to when they start feeling these suicidal thoughts, these suicidal urges. You want to look for family or friends that can provide support. I won't get too much into it, but actually friends seem to be the better resource for this. And it's important that on a clinical level, you're reaching out to these people and confirming that they're really buying in as a support person. There's nothing worse than a patient identifying a support person, and then when they reach out, that person's not willing to give the support that's being looked for. Some of the other things you can put on here, of course, you want to list the professional resources, whether it be the suicide hotline, the local crisis centers, those kinds of things. I've seen a lot that focus on means restriction. So there's a reminder that, you want to remove pills, remove firearms, and kind of limit access to lethal means is an important piece. But overall, this is one of the best tools out there for really helping reduce the risk of somebody acting on a suicidal urge. Speaking of resources, just kind of summarize here. I know I mentioned a couple of these in passing. I'll touch base on them. The National Action Alliance for Suicide Prevention is a very important resource. The Suicide Prevention Resource Center has lots of good tools for a wide variety of settings, not just healthcare, but all different healthcare settings as well as schools and other things like that. Part of that outcrop is zero suicide. When we hear somebody say, "Oh, you're not going to prevent every suicide out there," and if you don't have the goal to prevent every suicide and get that number down to zero, you're not going to reach it. So really, it is important to focus on trying to get that down to zero. I mentioned, I believe, a couple times that the Suicide Prevention Lifeline, they're always looking for partners, and then the American Foundation for Suicide Prevention as well. Also give a shout out to the American Psychiatric Nurses Association, who is now offers a suicide prevention competency for nurses and lots of other resources as far as creating safe environments and those things. And the last slide is just resources here, references that were used in the creation of this presentation. And Rick, I'll now turn the program over to you.
Thanks, Chris. That was a very informative presentation that contained valuable information everyone can use in their organization. That concludes our slide presentation portion of our program. Now we would like to begin our question and answer period. Chris, one of the questions that we have is, what do you think may account for the different rates of suicide in the male population compared to the female population?
It's interesting when you look at it that women actually attempt suicide more frequently than males. And the reasons for that might be, are up for debate. But typically men complete more because they choose more lethal means. So whereas, females may choose things like overdoses and things like that with a higher rate of rescue, men choose things like hanging and use of firearms and things like that are more final, more quickly, I'll say.
Do you have any information that focuses on the elderly population and our patients with dementia?
Not in this slide specifically. I'll refer you to either, and I can put that slide back up for you. Either the SPRC or the National Action Alliance do focus on both the older adult population and those with cognitive impairments. A couple of the tools we discussed, off the top of my head, I'll say the Columbia and the PHQ, I believe, have tools designed specifically for those with cognitive impairments. So that would be my recommendation of where to start looking for assistance with that population specifically.
We were interested in the Alliance Safety Plan versus the Contract for Safety in Home Care.
Okay. In home care, it's a little difficult. And really, it's when we talk about a contract for safety, it was always, whether it was written or verbal, that the person would say, they contract to come speak to somebody before they act on their suicidal urges, things like that. Making that blanket statement is not in and of itself useful or protective, but when you take the time and you build a rapport and you build that relationship between a clinician and a patient, that clinician becomes a very strong support person. So, and not just a clinician, but between any support person and a patient, you can form, I don't know if I like the terminology, but I called it an alliance for safety, to kind of say like, hey, I'm your support person. When you start to feel like this, will you reach out to me? And that's kind of the difference there. In home care, it depends on the type of home care. Is this behavioral health home care or, like follow-up nursing care, visiting nurses, things like that. It really depends on the strength of that therapeutic relationship. And if you're in a position where you're a strong support person that the patient feels comfortable reaching out to, that might be an option to discuss. That like, hey, it's still a good idea to have it written as a patient safety plan. But having that discussion and saying, hey, reach out to me when you're feeling like this and we can kind of talk through it is much better than just signing a piece of paper or giving a verbal, I contract for safety, which, was common in the past.
One additional question. In addition to a safety plan, what are some measures inpatient psychiatric facilities can take to mitigate post-discharge suicides?
Post-discharge suicides are a tough one. really, it's you want to reach out. It's very important to reach out to individuals that are the people's support person for collaborating information. Comes to mind a case I remember of an individual that was very upset around the holidays, going against what I said about being reduced, but was voicing suicidal urges if they didn't have an opportunity to see their child around the holidays. So the staff at the facility thought it was very important to get this person out of the hospital and back home to spend time with their child. And then it turned out that the patient's spouse had taken the child, and the patient left and didn't have an opportunity to see the child, and ended up did complete suicide. So to me, that's a very important piece, is kind of reaching out to that spouse, saying, hey, this patient wants to see the child around the holidays. It's very important. Are you on board with this? Those kinds of things. I've also seen follow-up calls are a pretty common and an effective method. Sending out cards just as a reminder that, hey, there's somebody here that cares about you. A lot of times that's enough. But really the best way to reduce post-discharge is to really look at your assessment at discharge and be discharging for the right reasons and have the person on board. And you really want to see what changes you've seen in those modifiable risk factors over the course of treatment. And did you really reduce the risk of suicide to a level that's comfortable and no longer indicative of the need for inpatient treatment.